Hello everyone, this video is about hypersensitivity 2 and 1 we dealt with the help of previous video. This video is about type 2, 3, 4. Once again we will be learning about type 2, 3 and 4. So this note is from EPG Pathshala, India, MHRD. So I'm thankful for the developing team for developing this note. Thank you so much. Now let's learn about this. Here we will be learning about type 2 hypersensitivity, rhesus incompatibility or erythroblastoma fetalis, hemolytic disease of newborn, value addition, Combs test, then plasmapheresis, then ABO incompatibility between mother and fetus, induction of hemolytic anemia by drugs, neonatal alloimmune thrombocytopenia, then transfusion reaction, type 3 hypersensitivity, localized type 3 hypersensitive reactions, Arthus reactions, generalized type 3 hypersensitive reactions, serum sickness, then type 4 hypersensitivity, mechanism of type 4 hypersensitive reactions, detection and examples, type 4 hypersensitive reactions, and phases of type 4 hypersensitivity, along with cytokines and chemokines involved in type 4 hypersensitive reactions, common inducers of type 4 hypersensitivity, and we will be having a quick summary of all these topics. Our learning objectives include what are the different types of hypersensitive reactions, how do these different hypersensitive reactions originate and their effector mechanism, to compensate the components causing these reactions, mediators involved and the effects resulted, analyze the beauty of regulated immune response which if becomes dysregulated or inappropriate can cause deleterious effects to hosts. So first let's have an introduction. After the three types of hypersensitive reactions which are included in this module, like type 2, 3 and 4. One we learned earlier. So type 2 and type 3 are immediate type of hypersensitive reactions, whereas type 4 is delayed type of hypersensitive reaction. Except type 4 hypersensitivity, it is cell-mediated immunity based. Rest all hypersensitivity types are, per the Gell and Combs classification, are humoral immunity based. Type 2 hypersensitivity involves death of cells bearing antibody attached to cell surface antigen. It can lyse the cells by complement activation, by induction of phagocytosis, or by antibody-dependent cell-mediated cytotoxicity or ADCC. Examples include blood transfusion reactions, hemolytic disease of newborn through rhesus incompatibility, antibody-mediated graft destruction, autoimmune reactions, etc. So type 2 hypersensitive reactions are immune complex mediated complement activation. Type 3 hypersensitivity reactions are immune complex mediated complement activation based hypersensitivities. Localized vasodilation and chemotactic neutrophil attraction are elicited by complement split products. The accumulation of immune complexes at the antigen entry site induce localized Arthus reactions, whereas circulating immune complex deposing at many sites cause generalized serum sickness. Examples include farmer's lung and pigeon's facious disease. Type 4 hypersensitive reactions involve activation of sensitized TDH cells on secondary contact with antigen, which result in secretion of various Th1 subtype cytokines and chemokines. These effector molecules help in recruitment and activation of macrophages. It is delayed type of hypersensitivity as the onset of reaction takes 24 to 48 hours in general. Various skin tests like Mantox test, contact dermatitis, etc. are common examples of type 4 hypersensitivity. So first let's learn about type 2 hypersensitivity. Type 2 hypersensitive reactions are humoral immunity based immediate type of hypersensitive reactions. They involve antibody mediated destruction of target cells. Type 2 hypersensitive reactions are humoral immunity based immediate type of hypersensitive reactions. They involve antibody mediated destruction of target cells. The antibody bound to cell surface antigen may lyse the cell by a number of ways, such as by activation of complement system, which ultimately forms membrane attack complex or MAC and causes formation of pores in the target cell leading to cell lysis. Then by serving as opsonin, enabling phagocytic cells with FC or C3b receptors to bind and phagocytose the antibody-coated cell. The antibody-dependent cell-mediated cytotoxicity or ADCC. In this process, cytotoxic cells promote target cell killing after binding with FC region or cell surface antibody through their FC receptors. Like target cell surface antigen, IgM or IgG, FC receptor, cytotoxic cell mediators. Antibody mediated cell cytotoxicity. Antibody bound to surface antigen on target cell binds to FC receptors. Antibody bound to surface antigen on target cell. Antibody bound to surface antigen on target cell binds to FC receptors present on cytotoxic cells, which upon activation release cytotoxic mediators to kill target cells. The clinical manifestations of type 2 hypersensitivity include rhesus incompatibility, transfusion reactions, neonatal alloimmune thrombocytopenia, organ transplants, autoimmune hemolytic anemia, etc. Let us discuss some of these manifestations in detail. Rhesus incompatibility or erythroblastosis fetalis or hemolytic disease of newborn. The rhesus blood grouping system is second most used blood grouping system after ABO group typing. It was named so after its discovery in the rhesus monkey by Carl Landsteiner and Alexander S. Weiner in 1937. An individual either has or doesn't have the Rh factor or a D antigen present on which he is designated as Rh positive or Rh negative. The clinical consequence of a non-recognized Rh factor, the hemolytic transfusion reaction or hemolytic disease of newborn or erythroblastosis fetalis, was reported by Phillips Levine and Rufus Stetson in 1939. The hemolytic means destruction of blood cells like blood lysis destruction. Similarly, erythroblastosis fetalis means lysis of red blood cells in fetus. These hemolytic conditions are caused due to incompatibility of rhesus factor between mother and developing fetus in mother's womb. When maternal IgG specific for fetal blood group antigens cross the placenta, they destroy fetal blood cells and cause this disease. It occurs when an Rh negative mother carries an Rh positive fetus. The Rh positive fetus expresses the Rh antigen, which Rh mother does not. The fetal blood cells remain separated from mother's blood by trophoblast. The fetal blood cells remain separated from mother's blood by trophoblast layers of placenta during pregnancy, but at the time of delivery, fetal blood from umbilical cord enters the mother's circulation. The Rh or D antigen on these fetal blood cells activate Rh specific B cells in mother, which result in the production of Rh specific plasma cells and memory cells in mother. These plasma cells clear the entered fetal Rh positive red blood cells from the maternal circulation, but the memory cells create a threat for subsequent pregnancy with Rh plus fetus. The subsequent pregnancy with Rh positive fetus activate these memory cells, which can damage the red blood cells of developing fetus after crossing the placenta. It can cause mild to severe anemia, brain damage, and even fatal consequences. Which we could see with the help of this picture. Mechanism of development of hemolytic disease of newborn due to rhesus incompatibility. First, Rh positive father and Rh negative mother. An Rh positive father and Rh mother negative mother can conceive an Rh positive baby. And if it's first pregnancy, there is no problem as mother's blood remains separated from fetus blood. But at birth or abortion, fetus Rh plus blood enters mother circulation. It activates Rh specific B cells in mother, which results in the production of Rh specific plasma cells and memory cells in mother. These plasma cells clear the entered fetal Rh positive red blood cells from maternal circulation, but the memory cells remain there. In the subsequent pregnancy with the Rh positive baby, chances are there to develop hemolytic disease of newborn at Rh negative antibody can cross placenta and react with Rh positive cells of fetus. So hemolysis, anemia, jaundice, brain damage, and even death of baby. So the subsequent risk of hemolytic disease of newborn can be almost prevented by administering anti-Rh antigen antibodies to mother with 24 to 48 hours of first delivery. These antibodies clear fetal RBCs that have entered the maternal circulation before they activate B cells or produce memory cells. These antibodies are called rogue. These antibodies prevent the hemolytic damage to subsequent fetus. Rh antigen, anti-Rh antigen antibodies. If a woman is detected with hemolytic disease, the treatment is decided on the basis of severity of reaction. If the case is not very severe, the infant is exposed to low doses of UV light to break down the bilirubin to prevent cerebral damage. So also mother is treated during pregnancy by plasmapheresis. In this technique, a cell separator is used to separate cells and plasma of mother's blood. Since it is the plasma that contains Rh negative, anti-Rh antibody is discarded. The remaining cells are reinfused into mother in fresh plasma solution. In other severe cases, fetus is given an intrauterine blood exchange transfusion to replace its Rh positive cells with Rh negative cells. Such transfusion reactions are repeated every 10 to 21 days until delivery. An value addition. Coombs test. Coombs test was given by Robin Coombs, Arthur Morant, and Rob Reyes in 1945. It is also called an anti-globulin test or AGT. Coombs test is of direct type or indirect type. Direct Coombs test is used to detect if antibodies or complement proteins are found to surface of RBC. The blood sample is collected and cells are separated from plasma. The cells are then incubated with anti-human globulin, the Coombs reagent. The test is confirmed as positive if agglutination of RBC is seen, which proves that the test is confirmed as positive if agglutination of RBC is seen, which proves that antibody or complement is bound to RBC surface. So what is Coombs reagent? Anti-human globulin. Indirect Coombs test detects antibodies against RBCs that are present unbound in the patient's serum. In this test, serum is taken from patient's blood and incubated with RBC of known antigenicity. From other patient blood sample, agglutination confirms the test to be positive. In Coombs test is used for cross-matching before blood transfusions, diagnosis of hemolytic anemia. So here we could see direct Coombs test or direct agglutination test. Blood sample from a patient with immune-mediated hemolytic anemia. Antibodies are shown attached to antigens in the RBC surface. The patient's washed RBCs are incubated with anti-human antibodies or Coombs reagent. Then RBCs agglutinate. Anti-human antibodies form links between RBCs by binding to the blood antibodies in the RBC. Positive test result. Then indirect Coombs test or indirect anti-globulin test. Recipient serum is obtained containing antibodies. Donor's blood sample is added to the tube with serum. Recipient IGs that target the donor's red blood cells from antibody antigen complexes. Anti-human IGs, Coombs antibodies, are added to the solution. Agglutination of red blood cells occur because human IGs are attached to red blood cells. Then next, plasmapheresis. Plasmapheresis means taking away plasma. Is a medical procedure to remove, treat, and return of blood plasma from circulation. Michael Rubinstein used this technique for the first time in 1959 to treat thrombocytopenia purpura. This technique is used as therapy against autoimmune disorders, erythroblastosis fetalis, etc. Generalized depiction of plasmapheresis technique is shown. Here you could see that. Plasmapheresis technique, which involves collection of blood from the patient, its separation into cells and plasma, absorption or filtration of plasma. Wait a minute. Collection of blood from the plasma. Blood is collected from the plasma. Its separation into cells and plasma, absorption or filtration of plasma, mixing of filtered or fresh plasma with cells, and transfusion back to the patient. So blood is collected, blood cells and plasma separated, cells, plasma, cells, and then returned. Plasma or absorber or filter, fresh plasma is returned. So collection of blood from the patient, its separation into cells and plasma, absorption or filtration of plasma, mixing of filtered or fresh plasma with cells, and transfusion back into the patient. Other type 2 hypersensitivity related disorders are ABO incompatibility between mother and fetus. In most of the cases, the hemolytic disease of newborn has minor consequences. These are because of ABO incompatibility between mother and fetus instead of RH incompatibility. ABO incompatibility. An O blood group mother carrying A or B blood group fetus usually develops anti-A or anti-B IgG antibodies. It can lead to fetal anemia, but it's mild only. It can cause bilirubin accumulation leading to jaundice. Exposure to low dose of UV is usually used to treat infant that breaks the bilirubin and avoid brain damage. For more severe cases, blood exchange transfusion may also be required. ABO incompatibility between mother and fetus. Introduction of hemolytic anemia by drugs. The non-specific absorption of some antibiotics like penicillin, streptomycin, cephalosporin to proteins present on RBC membranes forms a complex similar to hapten carrier complex. These complexes induce antibody generation which further bind to absorbed antibiotics and active complement mediated lysis and hemolytic anemia. Such a hemolytic anemia disappears with withdrawal of drugs or antibiotics. Then neonatal alloimmune thrombocytopenia. Next is about neonatal alloimmune thrombocytopenia. So in this disease, the fetus has decreased platelet or thrombocyte count. The platelet antigens are inherited from both the mother and father, but there are chances that a mother has no platelet antigen of its own and the child in mother's womb has got the platelet antigen from father. In such cases, it causes neonatal alloimmune thrombocytopenia because of maternal antibodies specific for platelet antigens coming from father. Generally, such thrombocytopenia is mild and remains asymptomatic. But in some cases, hemorrhage and particularly intrarenal hemorrhage can occur which can cause death. Then transfusion reaction. The red blood cells RBCs have a number of proteins and glycoproteins on their membranes. These proteins or glycoproteins are encoded by different genes. Transfusion reaction. The red blood cells have a number of proteins and glycoproteins on their membranes. These proteins or glycoproteins are encoded by different genes, each of which has various alleles. If a person having a particular allelic form of blood group antigen is transfused with the blood having different allelic form on its RBC, they are considered as foreign or non-self and an antibody response is generated. Let us consider the ABO blood grouping system first to understand these transfusing reactions. ABO blood groups are distinguished on the basis of difference in terminal sugars that constitute the distinguishing epitopes in A, B, and O antigens. The antigen group A and B are derived from B substances by the action of glycosyl transferase encoded by A or B respectively. The structure of these terminal sugars are shown. N-acetyl glucosamine, N-acetyl glucosamine, N-acetyl galactosamine, galactose, and fructose. O antigen, B antigen. So a person having A antigen on its RBC, A agglutinins, recognize B-like epitopes on intestinal microorganisms and generate antibodies to B-like epitopes. These antibodies against A, B, and O antigens are called isohemagglutinin. Similarly, a person with B antigen on its RBC, like B agglutinins, recognize A-like epitopes on intestinal microorganisms and generate antibodies to A-like epitopes. An O blood group individual has no surface antigen on RBC, whereas AB blood group individual has both A and B surface antigens. The blood groups in ABO blood grouping system are known below in the table along with their agglutinins and isohemagglutinin. Blood group or phenotype, genotype, agglutinin or antigen on RBC surface, isohemagglutinin or serum antibody. The blood group is detected on the basis of agglutination of RBCs by mixing blood of the individual with anti-A, anti-B and anti-D antibodies. A, B for A and B antigen and D for Rh factor. For example, the image below shows a blood A plus A positive blood group as the anti-A and anti-D antibodies agglutinated the RBC, which confirmed the presence of A and B surface antigens respectively. Anti-A agglutinated RBC, anti-B, anti-D. If a person is transfused with blood having surface antigens on RBCs different from its own blood RBC, a transfusion reaction takes place. The clinical manifestation of transfusion reaction involves antibody and complement mediated intravascular hemolysis of RBCs of transfused blood. There can be immediate or delayed transfusion reactions. Immediate transfusion reactions arise due to ABO incompatibilities, whereas delayed transfusion reactions results due to ABO compatible but other blood group incompatibility. In immediate types, hemoglobinuria, release of hemoglobin in urine is detected within few hours of transfusion. Fever, chills, bloating and nausea and other common symptoms. Some of the hemoglobin gets converted into bilirubin also, which is highly toxic at high levels. The predominant isotype in immediate type transfusion reactions is IgM, which is very effective in complement activation. In delayed type transfusion reaction, symptoms appear after 2 to 6 days of blood transfusion. Common blood group antigens known to cause delayed transfusion reactions are KIT, Tuffy and KEL, etc. Isotypes involved in these reactions is IgG, which is not as effective as IgM in complement-mediated cell lysis. Thus, there is an incomplete complement-mediated lysis of transfused blood cells in delayed transfusion reactions. Symptoms include fever, low hemoglobin, anemia, jaundice, etc. Since RBC destruction occurs at extravascular sites, there is no free hemoglobin detection in delayed transfusion reactions. The best strategies to avoid these reactions is to cross-match the donor and recipient's blood. Next, type 3 hypersensitivity. Type 3 hypersensitive reactions are humoral immunity based immediate type of hypersensitive reactions. They involve antigen antibody complex or immune complex mediated complement activation, which ensure inflammatory response mediated by neutrophil infiltration. In general, the antibody is complex with antigens and facilitates the clearance of this antigen-antibody complex by phagocytosis. But if there is an accumulation of such immune complexes, it leads to type 3 hypersensitive reactions. The strength of type 3 hypersensitivity depends on site and amount of immune complexes. The common sites of deposition of immune complexes are synovial membrane of joints, walls of blood vessels, choroid plexus of brain and glomerular basement membrane of kidney. Once again, synovial membrane of joints, walls of blood vessels, choroid plexus of brain and glomerular basement membrane of kidney. With the accumulation of immune complexes at a particular site, complement proteins get activated. The split products of complement proteins like C3A, C4A and C5A act as anaphylotoxins. With the accumulation of immune complexes at a particular site, complement proteins get activated. The split products of complement proteins C3A, C4A and C5A act as anaphylotoxins. These anaphylotoxic molecules increase the vascular permeability and cause mast cell degranulation. Some of these products like C3A, C5A and C5b67 act as chemotactic factors for extravasation and accumulation of neutrophils at the site of immune complex deposition. These neutrophils release lytic enzymes as they are unable to phagocytose the immune complexes deposited on basement membranes. C3b acts as an opsonin for binding to neutrophils. Aggregation of platelets and complement-mediated tissue damage are other mechanisms involved in type 3 hypersensitive reactions. Type 3 hypersensitive reactions can be localized or generalized. Localized type 3 hypersensitive reactions. An intradermal or subcutaneous injection to an individual carrying circulating antibodies specific for injected antigen at high levels leads to formation of immune complex which are localized and in high number. It leads to local Arthus reaction within 4 to 8 hours. The tissue with Arthus reaction shows adherence of neutrophils to vascular endothelium and then their migration to tissues at the site of immune complex deposition, which leads to localized vascular and tissue damage with edema and erythema. These Arthus reactions are known with various names, usually depending on source of antigen, like PGN Fancius disease. It's named so because it results from inhalation of serum protein and dust derived from dried pigeon fecal matter. Similarly, farmer's lung results from inhalation of thermophilic actinomycetes from mouldlead hay. And then a diagrammatic depiction of mechanism of a total Arthus reaction is shown below. Lytic enzymes, antigen, master cell, histamine receptor, neutrophil, C3A, C5A, C5B, 6, 7, lytic enzymes, neutrophil, lytic enzymes, immune complex, complement activation. Mechanism of development of localized Arthus reaction. So, then value addiction. Arthus reaction was discovered by Nicholas Mauritius Arthus in 1903. He observed that repeated subcutaneous injection of horse serum into rabbit resulted in edema and slow absorption of serum. Further injection led to gangrene eventually. Generalized type 3 hypersensitive reaction. Circulating immune complexes in blood arising due to large amount of antigen entered and bound with antibody in blood give rise to generalized type 3 hypersensitive reactions. The clinical manifestation of generalized type 3 hypersensitive reactions are called as serum sickness, which include vasculitis, fever, erythema and edema, weakness, arthritis, glomerulonephritis and lymphadenopathy. The clinical manifestations of specialized type 3 hypersensitive reactions are called serum sickness, which include vasculitis, fever, erythema and edema, weakness, arthritis, glomerulonephritis and lymphadenopathy. Though the immune complexes may deposit at various sites, but generally they accumulate more at the sites where filtration of plasma occurs, like kidney, arteries and synovial joints. That is the reason why serum sickness shows high incidence of glomerulonephritis, vasculitis and arthritis. Serum sickness is not the only pathogenesis. In case of immune complex mediated type 3 hypersensitive reactions, other common conditions are infectious diseases like meningitis, hepatitis, trypanosomiasis, etc. It's a type 3. Okay. Then drug-induced penicillin and sulfonamides. Autoimmune disorders like rheumatoid arthritis, systemic lupus erythematosus, Goodpaster's syndrome. I'm not sure about the pronunciation. Time after BSA injection, immune complex, free antigen, serum levels, serum sickness, VAB. Graphical representation to show correlation between immune complex formation and development of serum sickness symptoms. Ingestion of large dose of bovine serum albumin in rabbit leads to formation of antibodies and subsequent immune complex formation. The symptoms of serum sickness coincide with peak of immune complex formation. With clearance of these immune complexes, free circulating antibodies are left and serum sickness symptoms subside. Type 4 hypersensitivity. Type 4 hypersensitivity reactions are cell-mediated immunity-based delayed type hypersensitive reactions as compared to immediate type reactions. Delayed hypersensitive reactions take 48 to 72 hours to develop, and instead of neutrophils, macrophages are the major components. Type 4 hypersensitive reactions are cell-mediated immunity-based delayed type hypersensitive reactions. As compared to immediate type reactions, delayed hypersensitive reactions take 48 to 72 hours to develop, and instead of neutrophils, macrophages are the major components which are infiltrated at the site of inflammation. It was first described by Robert Koch in 1890. A simplified general overview of mechanism of type 4 hypersensitive reaction can be shown as entry of antigen, activation of sensitized Th cells, generally Th1 subpopulation, but some Tc cells are also involved. Release of cytokines like interleukin 2, interferon gamma, IL-2, IFN gamma, tumor necrosis factor beta, TNF beta, and macrophage inhibition factor MIF. Infiltration and activation of macrophages with increased phagocytic activity and increased concentration of lytic enzymes. Localized tissue destruction with lytic enzymes, type 4 hypersensitivity. Infiltration and activation of macrophages with increased phagocytic activity and increased concentration of lytic enzymes. Type 4 hypersensitivity is important to fight intracellular parasites and bacteria as they cannot be accessed by circulating antibodies. Thus, the phagocytic activity and lytic enzyme mediated destruction of infected cells is required to protect the host from such infections. But high-end response may lead to non-specific tissue destruction at the site of infection. The continued presence of pathogen with ineffective defense process leads to chronic DTH reaction. For example, lung cavitation in Mycobacterium tuberculosis infection and granulomatous skin lesions in Mycobacterium leprae infection are results of chronic DTH infection. Detection of DTH response by type 4 hypersensitivity. The presence of the DTH cells which have been sensitized earlier with an antigen can be detected by reaction to an intradermal injection of the same antigen. A characteristic skin lesion develops at the site of injection in a positive test which indicate the individual has sensitized a DTH population of that particular antigen. For example, an Antrax test or tuberculin test or purified protein derivative PPD test is done to test whether the individual has been exposed to Mycobacterium tuberculosis. In this test, PPD, a protein derived from cell wall, is injected intradermally and observed for development of firm, swollen, and red lesion on skin after 48 to 72 hours. Development of such a skin lesion indicate that the person has been exposed to Mycobacterium tuberculosis. Though it cannot be concluded whether the person was exposed to pathogenic form of Mycobacterium tuberculosis or the vaccine. Wash, inspect site, feel, mark edges, measure, then wash again. Record the readings of the appropriate form using only millimeters. Do not simply record as negative or positive. So this is a erythema. Reddening of the skin, do not measure. Induration, hard dense raised formation, measure. Only the induration, palpable raised and hardened area should be measured for interpretation. The reader should not measure erythema or redness. Wash hands or use hand sanitizer per facility protocol. Inspect the site. Locate the area where the skin test was administered. Inspect the arm and good site on a firm surface. Then feel induration. Lightly palpate the area with the pads of your fingertips to determine if there is an induration and to locate the margins or edges of the induration. In left, then feel induration. Then mark edges. Measure the diameter of the indurated area across the forearm perpendicular to the long axis and the widest width of the induration. Using a ballpoint pen, mark lightly one edge of the induration with a fine dot and then repeat at the other end. And measure. Use a millimeter ruler or caliper. Gently lie a ruler on the skin, placing the first mark at 0, first line on the ruler. The second mark will be the measurement of reading. If the measurement falls within 2 divisions on the millimeter scale, record the lower mark. If there is no duration, the induration the measure is as 0 millimeters. Wash hands to use with the help of hand sanitizer. Then record the reading on the appropriate form using only millimeters. Do not simply record as negative or positive. We need the length. Okay. Procedure for PPD skin test or Mann-Dox test. Mandox test. Interpretation of the tuberculin skin test reading. Skin test interpretation depends on two factors: measurement of the induration in millimeters, person's risk of being infected with TB, and the progression to disease if infected. An induration of 5 or more millimeters is considered positive in HIV infected persons, persons who had recent contact with another person with TB disease, then persons with fibrotic change on chest radiograph consistent in prior TB. Patients with organ transplants, persons who have immunosuppressed for other reasons like taking the equivalent of less than or greater than or equal to 15 mg per day of prednisone for 1 month or longer. An duration of 10 or more milliseconds is considered positive in recent immigrants within the last 5 years from high prevalence countries, injection drug users, residents and employees of high risk and great settings, mycobacteriology, laboratory personnel. Oh my god, sorry, that's kind of shocking for me. Then persons with clinical conditions that place them at high risk, then children less than 5 years of age, or infants, children, adolescents exposed to adults at high risk. And in duration of 15 or more millimeters is considered positive in persons with no non-risk factor for TB. Reading, how to read PPD test result in duration size. Similarly, other skin tests for detection of previous exposure to microbe causing leprosy and coccidiomycosis are done with lepromin and coccidiodin as test age antigens respectively. Also, the age progression can be detected by monitoring decreased skin sensitivity to any of various age antigens like haptens or antigens. And as age progresses, CD4 plus Th cells population decrease. Decreasing Th cells mediate a type 4 hypersensitive response. Contact dermatitis arise due to contact with chemicals like formaldehyde, trinitrophenol, turpentine, nickel, etc. Cosmetics like hair dyes, plants like poison oak and poison ivy are mediated by type 4 hypersensitive reaction. The mechanisms involve complex formation of these antigens with skin proteins, internalization of these complex by skin antigen presenting cells like Langerhans cells, processing and presentation of these antigens with class 2 MHC molecules, activation of sensitized TDTH cells. Internalization of these complex by skin antigen presenting cells, processing and presentation of these antigens with class 2 MHC molecule, activation of sensitized TDTH cells. Type 4 hypersensitivity generated due to poison oak is represented. Poison oak or toxicodendron radicans, pentadecacatechol. Skin self-protein, sensitized Th1, IFN gamma, Langerhans cells, APC, MIF, MCF, lytic enzymes, tissue macrophage and monocyte. Contact dermatitis. Okay, phase of DTH response. DTH response is divided into an initial sensitization phase. DTH response is divided into an initial sensitization phase and an effective phase. Sensitization phase lasts for 1 to 2 weeks after primary contact with the antigen. In this phase, Th cells undergo activation and clonal expansion by antigen presented with MHC2 molecules on antigen presenting cells or APC. Langerhans cells and macrophages are primary APCs involved in this response. The T cells involved in this phase are CD4 plus Th1 subpopulation mainly, but some CD8 plus TC cells have also been shown to induce DTH response. TDTH denotes activated Th cells or some TC cells, but only named so to denote their function in DTH response. Effector phase is induced with subsequent exposure of antigen. In this phase, sensitized TDTH cells secrete a number of cytokines which recruit and activate macrophages and other non-specific inflammatory cells to site of inflammation. Since it takes time for cytokines to induce localized influx of immune cells, the DTH response shows a delayed onset and become apparent after 24 to 48 hours of secondary contact with antigen. In cases where antigen is not cleared easily, a granulomatous reaction develops which can damage host tissues well. In granulomatous reaction, continuous activation of macrophages leads to adherence to these cells to form an epithelioid shape or multinucleated giant cell after fusion. Such giant cells displace the normal cells and create a palpable nodule. High amount of lytic enzymes released by these cells cause tissue damage or even necrosis. Initial infection, granuloma, superinfection. Granuloma formation due to chronic DTH reaction. An overview of phases of DTH response. Sensitization phase, intracellular bacteria, Th1 cells generally, CD4 plus Th. Antigen presenting cells, macrophages, Langerhans cells, DTH mediating cells, Th1 generally, CD8 cells occasionally. Effector phase, secreted IFN gamma, membrane at TNF beta, sensitized to Th1, resting macrophage, Th1 secretion, cytokines, IFN gamma, TNF beta, IL2, IL3, GM-CSF, chemokines, IL8, MCAF, MIF. Effects of macrophage activation, class 2 MHC molecules, TNF receptors, oxygen radicals, nitric oxide. Cytokines and chemokines involved in DTH response. The profile of cytokines observed in DTH response indicate that TDTH cells are primarily Th1 subset only. The cytokines involved in DTH responses are IL2 amplifies the population of cytokine producing T cells. IL3 and GM-CSF inducers of localized hematopoiesis or granulocyte monocyte lineage. IFN gamma and TNF beta facilitate extravasation of monocytes and macrophages. Chemokines involved monocyte chemotactic and activating factor MCAF. Chemotactic recruitment of monocyte to site of inflammation is performed by MCAF. Then migration inhibition factor MIF. It prevents further migration of monocytes beyond the site of inflammation. Common inducers: Mycobacterium tuberculosis, Mycobacterium leprae, Brucella abortus, Leishmania sp, herpes simplex virus, measles, variola, Candida albicans, histopalms, capsulatum, hair dyes, poison oak, poison ivy, etc. Common type 4 hypersensitivity induced classes with examples. Then, as per the Cell and Coombs classification, all hypersensitivities can be classified in 4 groups: type 1, 2, 3, 4. Type 1 and 2 and 3 are humoral immunity based hypersensitivity, which shows their symptoms in hours and hence termed as immediate type. On the other hand, type 4 is cell mediated immunity based hypersensitivity, which takes days to weeks to show its symptoms and is called a delayed type of hypersensitivity. Type 2 hypersensitivity is antibody dependent hypersensitivity. The antibodies bound to the surface antigens on target cells can lyse the target cells by either complement activation by promoting phagocytosis or by antibody dependent cell mediated cytotoxicity or ADCC. The clinical manifestations of type 2 hypersensitivity include rhesus incompatibility, transfusion reactions, neonatal alloimmune thrombocytopenia, organ transplants, autoimmune hemolytic anemia. Coombs test is primarily used to detect type 2 hypersensitivity in hemolytic disease of newborn and transfusion reactions. And type 3 hypersensitive reactions are humoral immunity based immediate type of hypersensitive reactions. They involve antigen-antibody complex or immune complex mediated complement activation, with ensuring an inflammatory response mediated by neutrophil infiltration. Then type 3 hypersensitive reactions can be localized or generalized. Then localized type 2 hypersensitivity leads to local Arthus reaction described by Nicholas Arthus in 1903 within 4 to 8 hours. The symptoms include edema and erythema. Examples are pigeon, Finch's disease and farmer's lung. Arthus reaction type 3. Generalized type 3 hypersensitive reactions include serum sickness, which shows vasculitis, fever, erythema and edema, weakness, arthritis, glomerulonephritis and lymphadenopathy. Type 4 hypersensitive reactions are cell-mediated immunity-based delayed type hypersensitive reactions as compared to immediate type reactions. Delayed hypersensitive reactions take 48 to 72 hours to develop, and instead of neutrophils, macrophages are the major components which are infiltrated at the site of inflammation. It was first described by Robert Koch in 1890. Type 4 hypersensitivity involves activation of sensitized TDH cells, release of cytokines, infiltration and activation of macrophages with increased phagocytic activity and increased concentration of lytic enzymes. Type 4 hypersensitivity involves two phases. Sensitization phase, activation and clonal expansion of TH cells. Effector phase, release of mediators to cause effector functions. Various intracellular pathogens and contact antigens are known to cause type 4 hypersensitive reactions.